Hi, and welcome back to my channel, Learning Biology with Dr. Vanessa, where we take difficult biological concepts and make them easy to understand. Today, we're diving into two essential terms in cardiovascular physiology, cardiac output and stroke volume. If you've ever wondered how your heart keeps you alive every single second of the day, or how your body ramps things up when you're working out, this one's for you. Let's get started. Your heart isn't just a symbol of love, it's a pump. And understanding how much blood it pumps tells us a lot about how well it's doing its job. Cardiac output is a measure of how much blood your heart pumps every minute. More specifically, this is the volume of blood ejected from the left ventricle or right ventricle into the aorta or pulmonary trunk each minute. This measurement tells us how well your body is getting the oxygen and nutrients it needs, especially during exercise, illness, or recovery. In order to calculate cardiac output, we use the following formula, where cardiac output equals stroke volume times heart rate. So let's break that down. Stroke volume is the amount of blood ejected by the ventricle during each contraction, and that is multiplied by the heart rate, which is how many times your heart beats in a minute, and this will give you cardiac output. In an adult, the average stroke volume is about 70 mils per beat, and the heart rate is between 60 to 100 beats per minute. So for our example, we will use 75 beats per minute. So if your heart beats 75 times a minute and each beat ejects 70 mils of blood, then your cardiac output is those 70 milliliters of blood times those 75 beats per minute, which gives you 5,200 milliliters per minute, or about 5.2 liters per minute. That's almost your entire blood volume every minute. The average adult human body contains about 5 liters of blood. Now that we've defined stroke volume as the amount of blood ejected by the ventricle with each contraction, the next logical question is, what factors influence how much blood is pumped out each time the heart contracts? Stroke volume is not fixed. It adjusts to meet the body's changing demands, whether you're at rest, walking, or engaging in intense physical activity. Your cardiovascular system needs to deliver the right amount of oxygenated blood to your tissues. To accomplish this, the heart regulates stroke volume in response to a variety of physiological signals. This regulation is primarily governed by 3 factors. The first being preload. This is how much the ventricles are filled or stretched before they contract. The next is contractility. This is how forcefully the heart muscle contracts, independent of the preload. And then there's the afterload, which is the pressure the heart must overcome to eject blood from the ventricles. Let's take a closer look at these 3 key factors. Preload refers to the degree of stretch in the ventricular walls at the end of diastole. That is during relaxation of the ventricles, so this would be right before the heart contracts. You can think of it as how full the heart is. The more blood that returns to the heart and fills the ventricles, the greater the stretch. So more filling would equal stronger contraction. And this relationship is known as the Frank-Starling law of the heart. This stretching is determined by 2 things. First, how long the ventricular diastole is, which is the time in which those ventricles are going to be relaxed to allow blood to fill the chamber. And secondly, venous return, which is the volume of blood coming back to the heart from the body. In general, a longer diastole and or more venous return will equal a higher preload and vice versa. An increase in preload leads to an increase in stroke volume. The more the ventricles are filled during diastole, the more the cardiac muscle fibers are stretched and the stronger the subsequent contraction. This allows the heart to automatically adjust its output to match the volume of blood returning to it. For example, initially during exercise, increased venous return leads to higher preload, and therefore a more forceful contraction and higher stroke volume. When heart rate exceeds about 160 beats per minute, then stroke volume usually declines due to the short filling time between contractions. There is, however, a limit to how much stretch on the heart will increase contractions. Excessive stretching, as seen in some forms of heart failure, can reduce efficiency. Contractility is the forcefulness of the individual cardiac muscle fibers in the ventricles when they contract. It refers to how forcefully the heart can contract at a given preload. So even if the heart fills the same amount, a stronger contraction means more blood gets ejected. We describe substances or influences that affect contractility as inotropic agents. There are two categories of inotropic agents. They include positive inotropic agents, which increase contractility, and negative inotropic agents, which decrease contractility. Positive inotropic agents often increase the calcium that's available during cardiac muscle action potentials, which will then enhance the force of myocardial contraction. Examples of positive inotropic agents include sympathetic stimulation. This would be through norepinephrine and epinephrine, certain medications like digitalis or dopamine, and an increased extracellular calcium level. These agents are often used in clinical settings to improve cardiac output in patients with heart failure or shock. Negative inotropic agents reduce the strength of cardiac contraction. This can happen by either blocking calcium entry into cardiac cells or by inhibiting sympathetic activity. Examples of negative inotropic agents include beta blockers, which inhibit the sympathetic division of the autonomic nervous system, calcium channel blockers, which reduce calcium influx, increase potassium levels in the interstitial fluid, and acidosis, which can impair enzyme function involved in contraction. These agents are often used to reduce cardiac workload in conditions like hypertension, arrhythmias, or angina. As contractility increases, stroke volume also increases, even without changes in preload. Stronger contractions eject more blood from the ventricles with each beat. This is especially important during sympathetic activation, such as during exercise or stress. Epinephrine and norepinephrine enhance contractility, allowing the heart to respond quickly to increased metabolic demands. Conversely, reduced contractility, such as in myocardial infarction or heart failure, leads to a decrease in stroke volume. Afterload is the pressure the ventricles must overcome to eject blood during systole. Think of this as the resistance in the arteries, especially the aorta and the pulmonary trunk. In order for the ventricles to pump blood into these areas, the pressure in the ventricles must be higher than the pressure in these areas. Afterload represents the resistance the ventricles must overcome to open the semilunar valves and eject blood. As afterload increases, such as in hypertension, then stroke volume tends to decrease, especially if the heart is unable to generate sufficient pressure. High blood pressure is a common cause of increased afterload. Over time, the left ventricle must work harder to push blood into the aorta, which can lead to hypertrophy and eventually heart failure if the workload remains elevated. In healthy individuals, the heart can usually compensate for moderate increases in afterload. But in compromised hearts, even small increases in resistance can significantly impair stroke volume. Your cardiovascular system is remarkably adaptive. At rest, your cardiac output is typically around 5 liters per minute, like we discussed at the beginning of this video. But during intense physical activity, that number can increase significantly, reaching 20 liters per minute in the average person and up to 35 liters per minute in well-trained endurance athletes. How does the body achieve this? Primarily through increases in heart rate and stroke volume. Stroke volume increases initially during exercise, but only up to a point. At very high heart rates, there's less time for the ventricles to fill between beats, which can cause stroke volume to plateau or even decline slightly. Understanding how cardiac output is regulated is valuable whether you're a healthcare professional, a fitness trainer, or simply someone interested in understanding their body better. It provides insight into important clinical and practical scenarios such as heart failure, where cardiac output is insufficient to meet tissue demands, shock, where tissues aren't getting enough oxygen and nutrients, and exercise training, where the goal is to enhance stroke volume so the heart can work more efficiently over time. Let's summarize this. So cardiac output equals stroke volume times heart rate. Stroke volume is then influenced by preload, contractility, and afterload. The heart also continuously fine-tunes cardiac output to respond to your body's needs, from rest to activity and everything in between. Quick quiz. Which factor increases during exercise? Preload, afterload, or contractility? Drop your answer in the comments below. Understanding how your heart adjusts moment by moment isn't just helpful for passing an exam. It empowers you to better care for your body and interpret what it's telling you. If this video was helpful, please make sure to give it a like and share it with someone else who's learning. And also, make sure to subscribe so that you never miss out on new content. I'll see you in the next video.